your body, even though, let's say in case of herpes or chickenpox, where you really don't develop much antibodies at first, your T cells will still remember, so they're able to kind of mount a response much faster than being a completely brand new entity. So those are the kind of the things. But if you had to give me a choice of I'd rather have antibodies than not, I'd rather have them, even if it's a little bit of it. Better than nothing. For sure, we know that if you've been exposed to it once, there's been a couple of documented cases where someone had COVID and then caught it again because it's been long enough that they got re-exposed or their immune antibodies went down. Usually, what we've seen is that when that person gets it, they're definitely not as bad as the first time. So I hope that answers your question about antibodies. Yes. So it's kind of a loaded question, and so the gold standard for viral test is a PCR, which is polymerase chain reaction. And what PCR does is it takes um, any portion or particles of the virus and amplifies it millions of times, and so we're able to detect extremely, extremely small, minuscule samples of a virus and see whether it exists or not. So PCR generally is considered the gold standard. Um, its sensitivity, and so in all medical tests, it doesn't matter what it is. It could be a strep test, a flu test, your cholesterol test, anything. There's two numbers that um, researchers, scientists, and doctors look at, and those numbers are what's called sensitivity and specificity. So a sensitivity of a test is you almost have to talk it out to remember what it actually means. So a sensitivity of a test is how sensitive it is to pick up the positives out of a group. Okay, so when we say this test is, let's say, 90% sensitive, that means if you had 100 people that you knew were positive and you did this test, 90 out of 100 would test positive. So that means you have a 10% false negative rate. Everybody follows me? So then you have your specificity. That is, if it is positive, how likely is it that it really is positive? So it's the flip side of the coin. And those are two numbers. So when medical companies are designing a test, they have an option. They literally can work with those numbers. And you can never have a test that is 100% sensitive and specific. So you decide based on how you create that test, how you invent that test, where are you putting your reliance on? And here's the reason. The more sensitive you make a test, the less specific it becomes. Because what you have to do is you have to throw a wider net out to catch those 100 out of 100. Well, in that regard, you're going to end up you're going to call some things false positive. So, it's almost like saying if I said, what's the best analogy I can give you? So the wider net that you throw out to increase your sensitivity, you end up damaging your specificity. So there is a fine balancing act that all medical researchers work with to say, I want a test that's, very sensitive, but I also want it to be very specific. And they work on those numbers. And again, the assays, the chemicals they work with, they can make it super sensitive where we pick out 100% of everyone that's positive. But when you do that, you've made that test so sensitive that it's going to erroneously pick some people that were negative as positive because you've let what you've considered the bar as what's considered positive very low to just basically let everyone in. So PCR is usually considered one of the best tests. Its sensitivity is in the high 90th percentiles, usually somewhere between 95 to 98%, and it's usually about 99.9% to 100% specific. So that's kind of as good as it gets. The problem with the PCR test is what I alluded to earlier, is that that's assuming that I swab you and I put that swab and run that test in a matter of hours because you're dealing with live biological substances. They're affected by temperature, they're affected by handling. The reason there's studies that have come out that the PCR tests now are running in the 80 percentile, Why? Because the time lag that it takes from the time the specimen is collected until the test is run. So before we had our own analyzers or machines, we did PCR tests and sent all the tests to Quest and LabCorp. Well, we could see, okay, we swab the patient at 9 a.m. Quest comes at noon and picks up our labs. Then we can literally follow it online, and we see, okay, this batch they picked up. Well, their main processing center is in Tampa. So I see, okay, this batch got checked into Tampa at 10:20 p.m. Then, okay, nothing happened at night. The next day, oh, Tampa's processing center is backed up. We're going to send it to Miami. Well, now it's on its way to Miami. Later that day, it's in Miami. Sat in Miami for a day. Oh no, it's not working. We're backed up too. We're gonna send it to Virginia, and that's why the test was. So now, by the time we would literally follow this who's clue of my lab, my swabs are going literally all. Sometimes they end up in California from Virginia because they're backed up crazy, and they're trying to figure out what is the quickest way we can process this. And for them, it's like, okay, if it stays in Miami, it's going to sit here for 4 days. Let's just overnight it to California, Virginia. So they literally are, and I have no idea what is happening to my swabs. Is it handled? Did it remain a temperature below 8 degrees Celsius the entire time? Did it suddenly warm up and somebody not pay attention and ruin my damn test results? So because of that, there are a couple of Harvard did a study where they looked, and when they actually compared the current process of PCR tests, the true data we're getting somewhere in the mid 80 percentile in sensitivity. Once again, because as you hear, virus is going to be present depending on types of surfaces from 12 hours to 48 hours to 72 hours, and those numbers continuously decline. So if I've swabbed you and that test ran 4 days later, there's no way I can tell you how accurate that result's going to be. So now, like I said, if we ran that test, if we had the capability and had the PCR machine right there and we swabbed you and bam, ran the test, that would be the best available, except that does not exist anywhere. Literally. There's no one that has access to a PCR machine that can check on the spot. And even now, Quest and LabCorp have improved their processes, and now we're getting the results back in about 3 to 5 days. But again, your test is still going to sit for at least 24, 48 hours before it's ran. What happens during that time? And once that chain of custody leaves our office, we literally have zero control over it, which is one of the reasons that we invested in our antigen test with the company Quidel, who makes the Sophia machines. So the Sophia machine is an antigen test, and that is a test that we use. That's a test that the White House has. It is considered currently the most accurate test. FDA approved it at a 96.7% sensitivity with a 100% specificity. So it's kind of as good as it gets. There's really, in my 20 plus years of being in medicine, I have not come across any test that has a sensitivity of 97% with multiple studies that they've done, and 100%. That means if you're positive, you are 100% positive. It's not even 99.9%. It's 100% specificity, right? And that's kind of as good as it gets right now. And one of the reasons that it is so accurate, the test is a great test, but also you're able to run those tests within minutes of collecting the swab. So I mean, it goes from nostril to the machine. And Jackie, people that have been to our office most of the time, from the time they come in to the time they leave, they have their test results within an hour or two. That's unmatched really anywhere. So that is what we use currently for testing. It's very accurate. We've had it where, we've had a restaurant call us. They have 120 employees. They went on their own somewhere, got tested, so now they need to test 120 people, and including, let's say, the one person that had it, and we'll go in blind, not knowing who was the one person that was positive, and we'll swab 120 people, 130 people, And then we'll come back and we're like, okay, this person's positive, and they're always like, wow, that was that one person that was positive. Like your test picked out that one positive out of 120 people. Like, yep, that's what it's there for. So testing is extremely important to be able to catch those people early on. Along the same line, it takes on with any test method known on this planet currently, it takes at least 48 to 72 hours post exposure until you can test positive. So, patients come in all the time. Like I was in an elevator with somebody yesterday. I'm going to get tested today. Worthless. You're not going to test, even if I dumped a bucket of COVID on you the day before, you are not going to test positive within 24 hours. It takes, and the longer it goes past 48 hours, the more reliable the test becomes. So that's one thing to kind of keep in mind with your employees, staff, whatever it may be, that if someone comes in and they test positive, on their own, or they hear someone got positive, you want to make sure you wait a good, because now you can test them, but, and if they're negative, don't, hang your hat on that and say, oh, they're negative. No, you got to know that, okay, we got an initial one to see if there's a change, but you want to have that person retested in 48 to 72 hours. And then if you have two negatives, that's a very good indication. Because, mathematically, if you have, if you take a 97% sensitivity and you do that twice, you're literally approaching 100%. So, any other questions? Both. We know 100% that the viral load that you take in has a direct effect on your outcome. You know, again, if I got 100,000 virus in me versus 10 million viruses in me, my immune system has, like I said, just like intruders, my defense has a significant more front to deal with, and those viruses, because the what gets people in trouble is the cytokine storm that happens. So cytokines are the chemicals that your immune system releases in response to an invader. And cytokines are good, usually. But imagine if I suddenly dumped 100,000, what do you call it, marshals or rangers here in Ponte Vedra and had them go door to door and kick doors down looking for some intruders. Even though those 100,000 people are friendlies, they're going to cause a lot of damage in their wake of going door to door and kicking doors down. So that's what happens is the coronavirus has a way of inciting such a strong response from your cytokines that you get a cytokine storm, and they all go to the site of where this is happening is the lung. So it's actually your own body's immune system that causes more of the damage, not even the virus itself. So the cytokines cause significant inflammation in the pulmonary tissue, and once there's edema and swelling in the lung tissue, now you don't have oxygenation happening, and this is why people are like completely normal. They're talking to you, but they're blue, their oxygen is low, and they just die because they physically cannot oxygenate. It's almost like carbon monoxide poisoning. So being able to reduce that cytokine storm is extremely important, to make sure that it's like you basically your own body, your friendlies are the one that are causing the damage to you. But at the same time, your own underlying health condition has a significant effect on your outcome. So we have had people that have, this is one of the reasons that typically your first responders and doctors and nurses have the worst outcome with COVID. If you look at, what happened in New York, Italy, some of the places that were hit really hard, the percentages of nurses and doctors that died from COVID was 10 times higher than any other profession. Because, if I'm trying to intubate you and I'm standing on top of you and there's positive pressure, air, and you have COVID, it's not a casual contact of you and I, having a drink at the bar. I'm getting millions of those viruses rammed down my throat. So those first responders, had it the worst because close proximity, you already have, by the time there's an ER doc on top of you trying to intubate you, you're in bad shape with COVID. So it's not you don't have a mild case of it. So what you're producing is significantly higher, and most of those, because they're on oxygen, uh, they're inoculated with significant higher amount of the viral load than what would be in a casual transmission. The thing about it is that I tell patients all the time, the viruses don't read CDC guidelines. They don't listen to me. They do what they want to do. This is kind of like hey, 14 days and you're good. No, it's wrong. You could be good in 8 days. You could be good in 21 days. We have patients that catch COVID. And again, depending on your viral load, your immune system, we've had patients that were positive because of travel. They want to get back to work, whatever. They've come back on day 5. I want to get retested. Bam, negative. 5 days later. That's how quickly their immune system shed that virus and was able to neutralize it. Okay, make sure it's not a false negative. Come back 48 hours later, day 7, 8, retest again, 2 negatives. So by the time that happens, you're 100% negative. If you have 2 negatives back to back, 48 hours apart after being positive, you consider negative. On the flip side, I have patients that test positive 4 weeks after they tested positive because their immune system not good, can't fight the virus, and those viruses are still hanging around. So anytime you see guidelines like that, okay, what happens if it's 14 minutes? What if it's 16 minutes? Did the virus suddenly give up on the 14th day, on the 15th minute? We know the idea is 100% correct. The longer the exposure, and particularly in an enclosed, there has still not been a single case of a transmission happening like outside. If all 20 of us hung out there and half of us had COVID, assuming we're not exchanging drinks and shots and hugging each other out, no one's gonna get. There is enough breeze. There's been quite a bit of studies that have been done that show even that just this, like, I feel this AC hitting the back of my head. There is so much air movement. They've done a study where they took someone in a 10 by 10 room, and one person had COVID, another person did not have COVID, and they used nuclear tags to follow the tracing of the particles. And if they opened a single window in that 10 by 10 room, it took approximately 17 minutes without any airflow for the particles to transfer from one side to the other side of the room. In normal speaking, when they opened one room, it took like 2 hours. When they opened one window, it took 2 hours now for those particles to reach the other side of the room. If they opened 2 windows where there was the slightest amount of draft, the other person on the other side of the room never even got it. So that's how much being in an open area helps versus an enclosed space with minimal ventilation and air movement. So I would not really go by any specific minutes. If there is I would always say that if there was a known 100% exposure, like one of your employees is positive, that person was with them for 12 minutes, I would still check them. I wouldn't go by, because it was 15, they may have not gotten it. Or if they were there for an hour, they definitely had it. Short of checking 48, 72 hours post-exposure, it's almost impossible to know. Because again, the viral load, was the person coughing? There's so many confounding factors that can change whether someone receives that transmission or not. Whether they're wearing a mask, not wearing a mask, what kind of a mask. Such a controversial issue. I believe that masks, my personal opinion, that they're not very effective for the general population. And there's really scientific reasons. This is not a political thing by any means. If you look at virologists and how they, this is not we're not fighting pebbles. This is not an acorn. Um, these are viruses. If you ever look at how virologists work with viruses that they don't want to catch, right? Let's go to the what it should be. They're not wearing N95. I mean, these masks are kind of worthless. Um, N95 mask is really the only mask that reduces it by 85 to 90%. And that's assuming that is, so when I used to be in intensive care at University of Florida Shands, and we would walk into the TB unit, so the tuberculosis unit is under negative pressure, so the door is all shut, it's on negative pressure, there's specific ventilation that's constantly recirculating the air, and when you go into the TB unit, you could be there for 15 minutes max, and you have to wear not one, but two N95 masks. Now, mind you, tuberculosis is about 100 times larger than coronavirus, size-wise, particle-wise. So you have to wear two N95 masks, and it has to be fitted. I can't just walk up and put an N95 mask and walk into the TB unit. I have to wear two N95 masks. Then the nurse is coming in. They're spraying things to make sure, am I smelling it? Am I not smelling it? Only if it's properly fitted, I walk in. I walk in for 15 minutes, and I got to come out because I'm literally going to pass out from my own CO2 that I'm breathing in. An N95 mask is not meant for you to wear 12 hours a day. It is meant for very, very brief interaction with someone that you know is high risk. You keep your distance, you hold your breath, you double up on the N95 and get the hell out. It is not, the moment I wear one and nobody's wearing, I mean, I don't see anybody wearing an N95 mask. And even when they wear it, half the time it's hanging down. The question really comes down to is, we have patients coming into our office like, oh my God, this is a COVID testing center. I'm going to catch COVID. I'm like, you are more likely to catch COVID anywhere else but here. Because at least our staff is fully protected. We wipe everything down after every single patient. But what happened when you went to pick up that can of soup at Publix? Were you wearing a glove? No. The 75 items you touched. When you go to the gas station and you grab that pump, who do you know the last 10 people that touched it? Yes, you're wearing a mask, but what happens when you grab that pump and then you touch your nose? It is a fallacy for our, like, it's kind of one of those things we pat ourselves on the back and it makes ourselves feel better that we are. But how many times are you, the same with gloves. I see people wear gloves and they wear the same glove all day long. Well, that's just your like second hand. The glove is meant to be like, I'm going to go touch something contaminated. I'm going to put a fresh set of gloves, go touch it, glove comes off. The moment you wear that glove more than 3 minutes and you touched your pen, your clipboard, your keyboard, that glove is no cleaner than your own hand. So there's really no point to even wear the glove at that point. And again, that's what people miss is they're not looking at the 75,000 ways that viruses are coming at you. And as I mentioned, when virologists are working with viruses that they do not want to contract, they are in a full rubber suit. They are in literally space suits with oxygen supply attached to them. They're not wearing N95 masks. They're not wearing gloves. They're not wearing face shields. They're not wearing gowns. So that's that. So we know that is the only way to protect. Anything else less than that is not effective. Now, the question is whether you want to put a value on it. Is it 20% effective, 40% effective? There's no data that can give you a number, which is why the guidelines have changed 75 times, depending who's talking that day. CDC guidelines have changed 10 different times. They don't even know. They have no idea. It's whoever is waving that flag that day and is pushing somebody. But as far as technically, scientifically, this thin thing is not protecting me. I mean, if I'm going to catch it, if I'm literally going to be exposed, I'm going to end up catching it. And at the same time, there is enough people that we see so many positives on a daily basis. It's like, as my father always said, if you go under the apple tree enough times, you're bound to get hit by one. at some point, we're all going to be exposed to it one way or the other. It's just whether it's through the vaccine itself, whether it's through the actual virus itself. But the idea that now I wear a mask at the office because I can, I'm dealing with patients. So even though I get tested every single day, I'm still dealing with patients. We're a medical facility. We're wearing N95 mask. I'm wearing a gown. I'm wearing a face shield because like I'm at the war zone. But I'm not in this false sense of security that if I just wear a mask and walk around, I mean, you guys seen it. Someone takes off their mask, they throw on the table. An hour later, they pick up that same mask. I mean, you might as well just put a sock on. I mean, that mask is as good as maybe 15, 20 minutes. The particles are way, way smaller than what any of these masks can protect. You have spaces. If you can smell, if I can light a match and you can smell it, guess what? The viruses can go through just as well. So, and this is the reason why an N95 mask is so uncomfortable. You can wear an N95 mask more than 30 minutes if I paid you because it really does protect the best. And even that is in the 90 percentile, 70 to 90 percentile. To get it in the high 90, you got to wear double, and it has to be what's called a fitted N95 mask, which super expensive. It's really meant only for hospital. And again, it's meant for very, very brief interactions where you considering that this is a very high risk situation, and then you exit as quickly as you can. As far as sure. Absolutely. We know that areas that, you know, we are constantly, people have a tendency. I mean, I saw data somewhere that a typical person touches their mouth or nose 160 times a day, some crazy number. So the areas that are high contact areas could be a huge area of pathogen for viruses and bacteria. So it is definitely, for us, all the door handles, all the patient seats, everything, all our clipboards get wiped down, with literally bleach wipes after every single, because we know there's a transfer. And again, it's impossible, anyone that comes in and says, I caught COVID from this situation or that person, usually is wrong because we have no idea. It's not a 2D board where you can just connect dots. I'll give you a simple example. One of our nurses had COVID like 3 months ago, and you would automatically think you're a nurse working at Avicenna where they see 100 COVID patients a day. You must have caught it from Avicenna. Like I would think so as the owner of the place. Except she was like, no, actually, my son got tested positive 5 days ago because he went to Ginny Springs party with all his friends and he brought it home and gave it to the whole family. So my lead nurse, who works in a COVID facility, didn't catch COVID at the office, but caught it from her 19-year-old son. And so all the things that we're not thinking about that we come in contact with that other people touch on a regular basis, thousands of times. As I say, you're more likely, I was at Home Depot a couple of days ago. I mean, it's packed. Everybody's touching something. Everybody's grabbing an item, putting it back, and then I'm literally standing there as an observer, seeing, okay, this paint counter, these two older ladies came, touched it, rested their purse on it, had a drink on it. They were leaning on it. They walked off. 3 other people came, leaned on that paint counter. They touched this. They touched the keypads on the credit card machine. They signed their hand. I mean, like, there's viruses there. I mean, this is how irrelevant of COVID. This is how we get flu every year. This is how 70,000 people die from flu and SARS back, a few years ago. It's because these are high contact areas, and it has nothing to do with your mask because you touched it, and then you're going to adjust your mask or rub your eyes or touch your mouth or eat, or the 75 of the things you do. And probably the steering wheel on your car and your stick shift, gear shift is probably the dirtiest thing that you touch on a daily basis. And It's just one of those. It is what it is. So, which is kind of more important. Our push to our patients and my friends and family is get your health in gear, because that's kind of your best defense, is having a proper nutrition. We know 100%, as I mentioned, diabetes, obesity is one of the number one risk factors for people not doing well, not for catching it. Anybody can catch it. It's a matter of how you do. So people always ask, are there things that you do? I myself, on a regular basis, like every single day, I take between 3 to 5,000 milligrams of vitamin C. Vitamin C is actually in hospital intensive care is used as an IV for patients that have COVID. Ascorbic acid, which is the actual chemical name for vitamin C, is one of the substrates that is probably the most important antioxidants that our body uses in our defense. Now, the type of vitamin C that you take is very important. The tablets that is available every day for $3 a bottle, they're pretty much garbage. Whatever you take, 99.9% of it is not absorbed by the body. It's pretty much kind of useless. So what you want what's called liposomal vitamin C. Liposomal vitamin C is vitamin C where each individual molecule of vitamin C is surrounded by a polysaccharide molecule, which is a fatty substance. And what that does is that allows it to actually pass the stomach, because the vitamin C is absorbed in your small intestines. The regular vitamin C that we take that comes in tablets, it is ascorbic acid, except it's just not physically. I think most of the studies show that less than 0.1% of it gets absorbed by the human body. That's how little gets in. If you have the liposomal vitamin C, more than 50% of it gets absorbed, which is an insane amount. So I purchased liposomal vitamin C on Amazon, and there was a time that you couldn't even find it anywhere because everyone was kind of hoarding it like toilet papers. So I recommend anyone, and mind you, vitamin C, liposomal vitamin C has been shown significantly to fight cancer cell. I mean, there's many benefits besides COVID of just taking vitamin C, particularly the liposomal kind, on a daily basis. So I myself take 3 to 5, and I make my staff take it. I tell everybody I can, take your liposomal vitamin C every day, 3 to 5 grams. You definitely want to take zinc. Zinc is extremely important in fighting viruses, because particularly COVID and flu, SARS, they use a zinc pathway to be able to enter the cells. So by having a high amount of zinc substrates available, it almost prevents the encapsulation of the virus to enter your cells. So I take between 50 to 100 milligrams of zinc every single day. Yes, exactly. The zinc that you want to look for, again, it's called chelated zinc, CHELATED. And a chelated zinc, again, is a zinc that absorbs a heck of a lot better than non-chelated zinc. So anywhere between 50 to 100 milligrams a day and it's good just for influenza. It's good for COVID. So I take that every single day as precaution. Those two, anyone over the age of 50, melatonin at nighttime has been shown to be significantly important. It reduces the chance of a cytokine storm. So melatonin, if you remember earlier, I talked about what happens in a situation where what COVID gets you in trouble is that it induces such a response from the immune system that you have an abundance. It's almost like scar formation. Think about it. The way we develop a scar, typically, like if you cut yourself, a signal goes and says, hey, we have this crack, we need to go fill it in with tissue. Some people have a propensity to go overboard. So you'll see keloid formation. You'll see some people will have their ears pierced and they'll have a mushroom hanging off, or if they get the smallest cut, they'll get a huge scar formation. Well, that's what happens because your body went overboard. Instead of just saying, I need to fill this spot, it was the more the better variety. And the same thing happens in a cytokine storm. Instead of sending an appropriate response to that infection, it sends 10 times the amount of cytokines, and those attack the lungs and end up causing your own problem. Melatonin has been shown significantly, and one of the reasons that it's believed that children do so much better with COVID than adults is because of their high natural melatonin levels. If you notice, most causes of insomnia and people having, no one has a problem sleeping when they're 12 years old. It's when we get up into our 30s and 40s and 50s, and the older we get, we have more difficulty being able to sleep because our natural melatonin levels reduce over time. So, for example, if you take a 5-year-old, their melatonin level, their natural melatonin level, and their blood level is somewhere about 5 to 5.5 nanograms. If you take a 50-year-old, it's 0.5 nanograms. So it's literally 10 folds less as the decades go by. So I force melatonin down my parents' throat every night, make sure they take their melatonin. And just taking 5 milligrams of melatonin at night has been shown to significantly reduce cytokine storm. Another thing that's very important is vitamin D. Almost 80% of the population is vitamin D deficient. I don't think I've remember it last time a patient came in and we checked their vitamin D level and it was anywhere near normal. Most people are extremely vitamin D deficient. And vitamin D is really is way more. It's almost, it shouldn't, there's debates that it shouldn't even be called a vitamin. It should be called a hormone. It's one of the most significant vitamins that we have, and it controls many aspects of our human body, including our metabolism, our immune system. And it's been shown people that are low in vitamin D significantly do worse with COVID or viral infections. So taking 5,000 IUs of vitamin D daily is very highly recommended. Generally anyways, because I guarantee every single person in this room is vitamin D deficient unless you take vitamin D. But it's been shown to significantly help with viral infections. Yes, ma'am. Sure. Yes, for sure. I mean, usually it's obviously your flu-like symptoms, but if there's one symptom that, like when someone and I try to get this out of them, and I specifically ask about it, is an just a relentless headache. Most patients that will have COVID will come in. They don't care about their body aches. They don't even care about the fever, but they're just like, no matter what I do, this headache just does not go away. And it's the one that they're like, I usually can take Excedrin, I can take my 800 Motrin, I've taken everything under the sun, and that headache is there. And that is kind of a huge, when someone says, do you have a headache? Have you taken, your Motrin tonic? Has it gone away? No, before I even tell you test, you have COVID. The loss of taste and smell is huge. It doesn't happen with everybody. I mean, probably more than half the people that have COVID will still taste and smell just fine. But if you do have a loss of taste and smell, I'll bet the whole practice you have it. So those are kind of, and then of course just your run-of-the-mill congestion. People coming in thinking they have a sinus infection. We check them, it's COVID. You know, they're still contagious. They're still contagious. And that's the thing. If they test negative twice, they're negative. And again, some people have a propensity to, and I see this with kids a lot. We'll have kids come in, test positive, 6 days later, they're negative. They have a really good, strong immune system. They're really able to fight it off. And then we have some patients that, I think the longest I have is I had a patient that was like positive for 5 weeks. It was an elderly lady in her late 70s, a lot of different medical problems. She got a pretty bad disease. But like 4 weeks later, 5 weeks later, she was still positive. And if they're positive, irrelevant of whether they feel, I mean, it's like, that's great that you feel good. Let's make sure other people remain that way so we don't give it to anybody else. And yes, right, because it really, and again, most of the time, and this is where, because going back to what I said, majority of people, now there's some people that, because of work, home situations. They're like, listen, I haven't left the house in 2 weeks. The one person I hung out with was my cousin that came and visited me, and he called me and he said he's positive. So in a situation like that, we know that, okay, that was the person that, let's say, gave. But for the majority of people, they may have a guess, but they have no clue. Like I said, because everybody's out and about these days. Most people at work, they're going to the store, they're going to the gas station, they're having contacts with other people. It's impossible to know. So knowing timeline 0 is almost impossible. So sometimes, and it can take, so think about it this way. You have half the people that remain asymptomatic through the entire disease process. So let's forget those people. But the people that become symptomatic, you can become symptomatic as early as day 3 to as late as day 7 or 8. So when someone shows up at the office symptomatic and is like, I started having body aches or chills or headache last night, they could have contracted it 7 days ago, 8 days ago. They could have contracted it 2 days ago. It's impossible to know. So which is why when they're now, so imagine they test positive that day. So their exposure could have been as old as 7, 8 days ago. So now if they come back 5, 7 days later and they test and they're negative, it doesn't mean that, oh my God, they had this amazing immune system that they got rid of the virus in 5 days. No, it's possible that they actually got it 7, 8 days ago. They waited on 7 days, so now they got clear on the 14th day, truly from when they actually got the virus, right? So because we don't know when the timeline actually really ever starts, that's why there's this wide range. That's why when people say, try to give very specific, oh, it's got to be 10 days, it's got to be 14 days, 7 days. Okay, 7 days from when? And no one can tell you that answer because we never know really when the exposure happened. So all we can go by is get tested. If you're tested twice negative, you're negative. That's what really matters. As far as treatment, people say, okay, let's say I'm positive. Then what? I mean, is there anything I can do? For sure. There is a handful of medications and treatment that we use currently. Obviously, you'll hear about Remdesivir, Regeneron's antibodies. So there's certain treatments that are available that are only available in a hospital setting because they're IV infusions and they're only meant for very high-risk individuals. But on an outpatient basis, there's quite a bit of data that Zithromax itself, despite being an antibiotic, has activity because, again, Zithromax works towards one of those pathways where even viruses are able to enter the cells and it's able to kind of close that loop. So we use Zithromax. As I mentioned, since what gets people in trouble is the cytokine storm and the attack and inflammation in the lung. Remember, it's not the virus itself, it's the actual inflammation that gets you in trouble. And we use dexamethasone quite a bit, which is a steroid, very powerful steroid that we use. And that has a significant improvement for, patients come in short of breath. We put them on dexamethasone and 48 hours later, they feel better. There's a medication called ivermectin that we use quite a bit. Ivermectin is a medication that is used for multiple different diseases, certain infections, certain viral, certain insect-borne types of diseases like dengue fever and so on. And it has multiple studies have shown that within 48 hours of you taking ivermectin, it reduces the serum viral load by 10-folds. So there's quite a bit of good studies available online you can look at. And so we prescribe, so any of our patients that come in and get tested, and that's really the difference between, I don't know if you go to, let's say, the Regency site or somewhere where you just go get a free testing or anywhere else. Yes, you may get a test, but let's say, depending on what your results, there's no interpretation. There's nobody there to tell you, hey, this is what you need to do. There's obviously no script because you haven't even seen a doctor or provider, and you're just kind of like, here's my result. I'm not sure what to do with it. With us, we actively, if you're someone that is generally healthy, we contact the patient immediately and say, hey, listen, you're positive. And we collectively discuss whether we're going to just let it ride, which we do many times. If you're younger, pretty much most of my patients under 30 that truly are healthy and don't have any of the underlying health conditions I discussed, We don't do anything. Stay home, hydrate, take your vitamin C, take your zinc, take your vitamin D, you'll be fine. And they always are. Once you're past 30, 40, now we're depending on level of symptoms. And again, there are people that are positive that are asymptomatic, and there are people that are positive symptomatic. Definitely, if you're asymptomatic, we're not going to treat you because, again, your kind of first rule of as a physician is do no harm, and no reason for me to add medications that potentially may even have a 1% side effect if you really are asymptomatic and you're not going to benefit from it anyways. So, but if you're symptomatic, that's a different story. Obviously, we'll, depending on the level of complexity and how bad you feel, we'll throw everything in the kitchen sink at you, and if it's even worse, we'll send you to the hospital if it needs be. But there's this misconception that there's no treatments available, and it sucks, and you just got to deal with it, and it's definitely false. If you are, and particularly with ivermectin and Zithromax, because ivermectin reduces your viral load significantly, like tenfold within 48 hours, it significantly helps in reducing the propagation of the virus as well. If you happen to be under the same, unfortunately, most people that come in, they're married, they got kids, and they can only quarantine so much. Like I live in an 1,800 square foot house. How am I going to quarantine from my 3 kids that crawl on top of me every day? It's difficult. So trying to instill, and use medications to give them the best chance possible is kind of paramount. Questions? So we've talked about kind of where things have been. One question I always get is this going to go away? Probably not. I mean, it's going to get worse before it gets better. And when I say worse, because flu season really hasn't hit yet. And it's coming. And flu season this year is probably going to be worse. And so now you have your typical, at Avicenna, having done this now for 15 years, November to March is our busiest time. And this is before COVID. Just because, and again, people that are not in medicine don't take flu seriously. And again, we lose 60, 70,000 people every single year due to influenza. And again, who's taking precautions? I think, but the fear is heightened now, right? So last year in December, if you had the body aches and flu, you just told yourself, I got the flu, and you stayed home. Now, you're almost creating a panic situation. So you wake up with 102 fever. Now you got to call your employer. I got fever. Now contact tracing. Now we got to test 50 people. Then, so that it just creates a heightened level of anxiety, which increases need for medical services, testing, people being out more. Like it just feeds. It's a kind of a fire that feeds itself. Until, if you look at viruses, epidemiologically are assigned a value called an R naught value. And an R naught value is a value that one person, how many people can they infect? So one of the highest R naught values of any organisms out there is the measles virus. So measles has an R naught value of 18 to 20. That means one person will infect 20 people, which is insane. So if you think about how exponentially that grows, that means one gives to 20, those 20 each give to 20 other people. And then if you follow that math down 5 folds, we're already into the hundreds of thousands. That's how crazy measles gets. Your typical respiratory type viruses have an R naught value of somewhere between 3 to 5. So your flu, it's believed COVID has an R naught value of 3 to 4. So one person can infect 3 to 4 people. The only time the infectious rate goes down is when the R naught value becomes 1 or less. As long as the R naught value is above 1, that means it's like a self-feeding fire. It just keeps itself. 1 gives to 2, 2 gives to 4, and it just keeps going. So how that happens, like what happened with SARS, is you roughly have to have about 30 to 40% of the population to be exposed to the disease and develop either antibodies through vaccines or through self-auto antibody that you develop. And now there's enough herd immunity. So when you hear herd immunity, for example, all that means is probably the most significant important thing is 100% of the population doesn't need to have COVID for us to not worry about it. Once about 30 to 40% of the people have COVID, there is enough people within the community that block that transfer of a one-to-one transmission that it rapidly declines. So for example, I'll give you an example. Let's say two scenarios. I'm someone that is a virgin and never had COVID. Jackie has COVID. Me and Jackie go grab a drink. I'm the virgin one. I catch COVID. Now, when I go to work later today, I give it to 4 of my staff. And let's carry that math down. On the flip side, let's say I'm one of those 40% that have had COVID. Jackie's got COVID and doesn't know it, and her and I sit down and have a drink. I am my office staff best defense because I've had COVID before. Let's say in the second scenario. So now when Jackie and I hang out and have a drink and hug it out, guess what? COVID just bounces right off of me because I've already had COVID and I'm immune and I have antibodies. And now when I come to my office, guess what? Those 3 people no longer got COVID because I acted as a blocker. So Jackie giving it to my staff isn't happening because I'm someone that's already positive. So that's what so now imagine you multiply me throughout the community. Now it's like that pinball machine. There's not that direct transmission. Every time someone wants to pass it on, there's a chance that that virus is coming in contact with someone that's already immune. And so when you're immune, you can't even pass it on. You can't get it and you can't pass it on, which is why like if you have friends that have already had COVID, those are who you want to hang out with because you definitely can't get it from them. Yes, sir. No, I said that if you don't develop antibodies, it's the flip side. It doesn't mean. So we know that the antibodies decline over time. What we do not know is, do you have to have all the antibodies you started with? Do you need 50% of it? Do you need 20% of it? That's what we don't know. We know for sure if you have good enough antibodies, you're not catching it. Anyone that has antibodies is not catching the disease. The people that have, there's a handful of cases in the country where someone has gotten COVID again. And what's happened is when they check them, they see that their antibodies level had declined to 0. And that's essentially, or as I mentioned, some people never develop antibodies if they had a very mild disease. The question that is remained, what I was alluding to earlier, is that we don't even know if your antibody level is 0, that whether you're not protected, because again, we have the T cell immunity that we can't measure. So you have your B cell that produced your IgG and IgM antibodies. Those are measurable, but your T cells, the immunity that your T lymphocyte cells produce, are not measurable. And we don't know that, hey, if your antibodies have declined 80%, does that mean if you catch it, do you get a lesser disease? Do you get or do you not even get it if you have 20%, 30%? And that's what we don't know. But for sure, someone that has had it, that is antibody positive, you're not catching COVID from them versus someone that is brand new virgin who's never been exposed to the virus itself. I think it's fantastic. I mean, there's still a lot to be, we're not going to see it for at least probably 3 to 6 months. And then how it's going to be rolled out. I mean, they're saying hopefully next year they'll be able to produce 1 billion doses. 1 billion doses serves 500 million people because it's a 2-dose treatment. And again, Pfizer has interest in the entire world, not just United States. And again, really the question becomes how soon it can be deployed, whether people will take it. And there's quite a bit of fear from people that are like, I have plenty of my own friends and staff, like, I'd rather just get COVID. Just give me COVID and I'll be done with it. I don't want to take a vaccine that some pharmaceutical company made in a short, fast time. And it's a very reasonable response not to, I was a national speaker for both Pfizer and Johnson & Johnson. And I don't trust everything that the pharmaceutical companies tell us. Anytime there's money to be made, some corners could be cut. Absolutely. And again, the Pfizer has come out and said they've had more than 90% success, which is incredible. Just to give you an idea, our flu vaccines that you guys take every year sometimes has a 20% efficacy. Like, that's how crap flu vaccines are usually. Because with flu, just so you know, it has to be predicted a year in advance because there's many, many different strains of flu. The reason you might sometimes hear like the avian flu, all flu viruses come from birds. So the cycle that happens in a 12-month period, it first goes to birds and then from birds comes to us. So like the flu vaccine that's coming out now, they were predicting this in February or March. And what they do, there's literally people from NIH, CDC, along the highways of America that pick up dead birds and send them to the lab and have them tested for different types of influenza virus. And since they can only put, 12, 13 strains in a flu virus, and we have over 110 of them, it's a guesstimate of guessing, hey, we think based on the surveillance of all these dead birds that the most likely strain of flu or the subtype is this. And then it's guessed 8 months in advance, 6 to 8 months in advance, and then we wait until it actually hits, and we're like, we missed that mark. Sometimes it's been 100% miss, where they completely got all 13 wrong, and some it's right on the money, and but even when it's been a good year for the flu vaccine, its efficacy has been 70%, which is great. If you can give it to 100 people and prevent 70 influenza cases, that's great. So for Pfizer to say that this has a greater than 90% efficacy is out of this world. Hats off to them. Assuming that, and again, obviously there were people that had significant amount of, I wouldn't say significant, but they had side effects. They had the same body aches, chills, headaches, because you feel like you got sick. So again, there's some people that are going to, just by himself, are not going to want to do that. So it's going to be interesting this next few months. Moderna is coming, there's Regeneron, there's Moderna, there's several companies that are coming out there with their own cocktail of different things. But the ones that seem to be the most efficacious also seem to have the highest side effect profile. Yes, sir. Oh, man. This is one of those, it's almost at the realm of, I think there is, I'm not sure whether, I would say overall, yes. My general feeling is that if you took out all the media, if you took out all the hysteria, this year I haven't seen more deaths at my practice or more morbidity and mortality than any other year. We're just busier. Is COVID real? 1,000%. Does COVID kill people? 1,000%. But so does everything else. And our biggest difficulty as physicians is not coming across as crass. But there's a fine line between stating things the way they are, because that's just life, versus coming across as someone that may not be caring. And what I've said from the beginning is that everybody's got to die from something. We all, as a part, most people thank God, go through the whole life and they never see one person die in front of them. When I used to be, the reason I left Shands is in a single 24-hour period, I had to pronounce 7 people dead. I had to have 7 different family meetings say, your father's dead, your brother's dead, your son is dead, your daughter is dead, and that kind of sucks, which is I left. I could only do that for so long. No matter how strong and cold-hearted you are, that will get to you. But this concept of, and and I have physician friends all across the country. There's the number of deaths that are associated or related to COVID are significantly and falsely elevated. I mean, I hope none of you guys actually believe those real numbers as 100% causes of COVID. Many people, I have many of my physician friends that work in hospital system within Florida and other states where their administrators met with them and said, if it is because, especially the first 4 or 5 months when there was really not a lot of testing, hospitals were busy. I mean, if you came in and you died and you had a fever, they never even checked, and that was marked as COVID-related or COVID-like illness, and those numbers were counted by the CDC, and that's just the way it is. You have to imagine there is one usually department in a hospital that is the losing department, revenue and monetary wise, and that's the emergency room. Every other department in a hospital makes money except the ER. Except since March, the only department that's been open is the ER, and all the other departments shut down. We literally just, I think starting July, they were allowed to do orthopedic surgeries and colonoscopies and so on. Everything was shut down. So hospitals, and as my friend said, not that they were doing this because they need to pay their yacht payments. Physicians had their salaries cut by 25%. I have friends of mine here locally at St. Vincent that had their salaries cut by 30%, 40%. People let go. There was no patients to see unless you were in the ER. So orthopedic, cardiology, GI, any of these departments that have massive amount of patients and they do procedures and surgeries and obviously have revenue for the hospital, all those were zero. So when the stimulus package comes out and says, hey, if you have a COVID-related death, the hospital is going to be reimbursed $39,000. And if you're the hospital administrator facing your hospital that's about to close down, guess what? The grandma that came in with a fever that you didn't test is going to go down as a COVID-related death. All day, every day, and twice on Sunday. And if you believe anything different than that, as Jackie will tell you, I have very close ties and relationship with law enforcement. I mean, I've had different members tell me they found the guy in the parking lot of the hospital that had OD'd, literally with a needle in his arm. They took him to the hospital, and the next day when they went to go check for another reason, that patient was marked as COVID-related death. And he's like, I found the needle in his arm. Like, he OD'd in the parking lot of the hospital. So there is this, how, and it goes beyond obviously this conversation, but with kids affected, not being able to go to school, education, businesses that have closed, you got to kind of look at if the medicine is worse than the disease itself. Again, that's what comes down when we're talking about whether there was an overreaction or not. Like I said, 60, 70,000 people die from the flu every single year. And those are really, they've died from the flu. We've had, one of my close friends is an oncologist, and he's like at the hospital. Every single one of my patients that dies, that's end stage, stage 3, stage 4 cancer. They're being marked as COVID-related death. So, and that's the question. And some of them, and again, that's the question and it's not going to be addressed because it's just not politically correct to talk about on either direction, is if grandma's got stage 4 breast cancer and let's say, and is in hospice status and has been told she's got 3 months to live, and let's say she actually catches COVID and passes away. Do you say she died from COVID, or do you say that she had stage 4 breast cancer and she had 6 weeks to live? And these are the things that are not discussed. You're not going to hear it on CNN. You're not going to hear it on Fox. But that's just the reality of it. All we can do is, like I said, do what we need to do to protect ourselves. And like I said, it's kind of a personal responsibility because now that it is in the forefront, you can't ignore it. It's just kind of, it is, we can talk about it, the woulda, coulda, shoulda, but it's here. We have to deal with it. Most important is to make sure you're protecting yourself, you're protecting your loved ones, and you're taking the measures, because what's going to happen in 2021, it's this is where you're going to have litigation, and employers not protecting them. I mean, that's what's coming. I hope you guys realize, next year, already the attorneys are trying to figure out ways to somehow benefit from this one way or the other. So, including myself, my staff, now we're kind of in a CYA situation where you got to make sure you cover yourself in every aspect, and we want to make sure we're not letting things slip where someone unsuspected, like the poor gentleman, 51 years old, whose son gave him COVID, passes away. And like, that sucked, you know? Any questions? Absolutely. Glad I could help. If you guys have any other questions or any other situation, obviously Jackie knows how to reach me, and we'll go from there. All right. Absolutely. Thank you.